I welcome all my audience to this module of Pulmocon 2020, although it is 2021 now. And I thought that COVID has taught us a lot, and there has been too much of noise with COVID. People know much about COVID, and people are sick about COVID, listening to lot many webinars, lot many talks, so many things in the social media and all. But after, say, staying 9 to 10 months with COVID, it is important to look back and see what we have learned from it. And as a physician, I felt that it is my duty to make an opportunity for my colleagues to have an insight about COVID. With that purpose, I framed this particular session, and I'm very lucky that my senior revered colleague, Dr. Abhijit Bhattacharya, has agreed to be the chairperson for this session. Dr. Bhattacharya is a very eminent and very respected physician in the country, in the city also, and he's naturally he has got a long experience of 30 years, over 30 years, and his core interest is basically internal medicine and critical care medicine, and he actually travels from one area of medicine to another area so freely. That is what seeing that at one moment he's in diabetes, the next moment he's in hypertension, the next moment he's in myocardial infarctions. This is a beauty of an internist who can travel to all the areas. The next moment he can go to bronchial asthma. So he's a super specialist in true sense for all the subspecialties. So presently he is attached to AMRI Hospital and Sri Aurobindo Seva Kendra at South Calcutta. And with this brief note, I am obliged that he has agreed to be my chairman today. May I request Dr. Bhattacharya to take chair and preside over the next part of the session. Dr. Bhattacharya, please.
Thank you, Partho. Thanks for those kind words and for asking me to be here today with these well-known experts in their respective fields. I think to begin with, what COVID has taught us is of frailty and fallibility of human life, like no other recent event, this has been brought forth very evidently. And in fact, in this process, we have lost a lot of friends and colleagues, youngsters and old alike. So I think I'd start with a sort of, kind thought about those who have lost due to this COVID in recent times. So with these words, I think I will invite our first speaker, Dr. Narayan Banerjee. Dr. Banerjee is an eminent consultant physician and with a vast experience, with several publications to his credit. And he has area of interest is infectious disease, COPD, treatment of diabetes, and so on. And he's presently with Zenith Super Specialty Hospital in Kolkata. Narayan Banerjee.
I am an internist. I will share my experience of COVID-19 from March 2020 till date, which I came across during my day-to-day practice. Now I can divide the whole thing into the 3 times. Actually, from March, April, May, this is the phase 1. June, July, August, this is the phase 2. And now the phase 3, to me, it is going on. Why I have divided this into 3 things? Because in that phase 1 era,
Hello.
we were
Can you hear me?
Not sure.
Partho, can you hear me?
Patient of COVID.
I can't hear.
Dr. Narayan, please continue. Doctor, please keep yourself mute.
Right.
August, this is the phase 2. And now the phase 3, to me, it is going on. Why I have divided this into 3 things? because in that phase 1 era, we were actually not sure how to treat the patient of COVID 19, what are the complications, and uh, institutional treatment, or will treat the patient at home. That was totally not clear. And there was a panic, the panic between in the patient, panic in general population, and moreover, there was tight lockdown all over the country. So there were a lot of problem of keeping the healthcare system in intact, up to date. So the phase 1, I'll start my discussion as I am an internist as well as a director of a hospital. I've seen the evolution of the management of this COVID 19 from the very beginning. First, we have seen, I think, in the second week of March, there is increased incidence of viral pneumonia. At that time, there were a lot of news that Europe is being affected. There's lockdown in the US, lockdown in the Europe, different countries, and the Wuhan story was over at that time. So at that time, we were treating the patient with just supportive measure with oxygen, antibiotics, and nothing else. And testing done for RT-PCR in the second or third week of March, it was really difficult. I still remember the first case which I have detected in our hospital in the end of March. Unfortunately, that patient had several comorbidity, including he was on maintenance hemodialysis, diabetic, and that patient had pneumonia. And I have seen in CT this peripheral GGO, which was described in world literature as a viral pneumonia, classical of COVID, and patient was ventilated. Ultimately, patient expired. Possibly that was the second death in West Bengal. And there was no protocol till 31st of March when the central government and our West Bengal government came out with a protocol about COVID-19. What did that protocol say? That protocol was a generalized protocol of any ARDS patient, how to manage, and there was nothing about steroid. There was nothing about this anticoagulant, which is the mainstay of the treatment. And moreover, this panic was like anything. Everybody in the healthcare, whether he's a doctor or or he or she is a nurse or sweeper, if any patient comes with fever and shortness of breath, everybody was scared. And there's a scarcity of the PPE also. I still can remember one PPE was costing around 1,500 rupees. And donning and doffing, at that time, it was difficult to do in a general hospital. So, in the month of March, April, and May, we have seen the patient, we have admitted the patient, we have treated with them with oxygen, and we have used low molecular weight heparin. But at what dose? It's a prophylactic dose, what we used to do in any case of pneumonia. There was no idea about the prothrombotic state of this disease. Use of steroid at that time, what was mentioned by the government of India and West Bengal government protocol, that use methylprednisolone 1 milligram per kg of the body weight for maximum 5 days. And it was specifically mentioned at that time, don't use steroid much because it will reduce the immune system. Just treat conservatively, and there are a lot of other issues also. There are a lot of social issues that I will discuss again in other module. But at that time, really, we were we don't know what we're dealing. We know what are dealing. We don't know how to treat and when to discharge. The main difficulty. Initially, it was decided that the patient can be only discharged one how he or she became RT-PCR negative. And at that time, it takes around 48 hours to get the RT-PCR report. And if you get a person positive, after say 14 days of isolation and the treatment what was suggested at that time with hydroxychloroquine and other antibiotics with plus minus low molecular weight heparin, and it will come again positive. So patient had to stay again for another 10 days. You'll have to repeat the test. So it takes around, say, I know one patient who was discharged, though he was absolutely fine, only after around 3 to 4 weeks of stay. So at that time, now the different Indian company came with PPE, personal protective device, with very low cost. So much so, you can't imagine the same quality of CPP, what we used to do, what we used to use in the month of March, with the cost of one PP 1,500, it became 150 to 200 only. And there were lot of knowledge amongst us by different webinar, which was new to us. We never used to do webinar before. And finally, the breakthrough come in the month of June, I think. April, May, June. It's in the June end, the first time the Indian government came with the definite regime of treating COVID-19 and how to manage COVID-19 at that time. So I'm going into the phase 2 of the problem. So that modified protocol says that you should use steroid as a first dose, first drug. You should use oxygen, so much so that you have to keep the saturation around 95% initially. And once the patient is stable, you may keep between 92 to 95%. And the importance of low molecular weight heparin. And I think till now, these three are the only medicine which works. And they emphasize the importance of the comorbidity. The comorbidity, which includes diabetes, associated cardiac disease, chronic obstructive pulmonary disease, and definitely obesity. And it teaches that it is better to avoid ventilation as far as practicable. Go for non invasive, either by high flow nasal oxygen, or if you see by NIV, and awake prone position to maintain the oxygen saturation. Now, at that time also, institutional treatment was the modality of the treatment. And at that time also, the people were scared about the COVID patient. If you find a COVID patient in your area, that particular house become untouchable. And that time also, our healthcare worker faces lot of problem of going home, going to their house, because there was some barricades, some persons were they were not allowing them to enter into the housing complex. So there were a lot of problem we had faced at that time. But the treatment modality was decided in the month of June, first week. Now, the importance of the home isolation and treatment at home, a safe home concept, came in the month of July only. And that actually changes the whole picture. If you have mild COVID, asymptomatic, you forget. If you have mild COVID, you isolate yourself. You please be in your room, and there is a definite government guideline how to how to be safe in an isolated area and when to get admitted. That reduces the burden to the healthcare system a lot. And I used to advise many patients through this WhatsApp or through different audio visual aid, the how to be there, how are they, the importance of the pulse oximeter at home. But I never encourage anybody to keep oxygen at home in case if he deteriorates. I've told them specifically, if you have seen your oxygen concentration, saturation is less than 94, get admitted. The, the importance of immunomodulator as with steroid for reducing the cytokine storm was well established few months ago by UK study. And now the time has come. At that time, there are a lot of enthusiasm about tocilizumab, the IL-6 inhibitors. And government has again, in the month of July, they used to modify their guideline, I think every 2 weekly. They came with the guideline in the month of July or in the early month of August. What are the what are the investigation we should do in a patient of COVID, and what are the prognostic factor which determines which patient will deteriorate and which patient will not. And there comes the prothrombotic role of COVID. And we used to send each and every patient D-dimer, ferritin, C-reactive protein in the initial workup as well as interleucin IL-6. But after using IL-6, the experience shows that it causes lot of problem. The chances of infection and others are much more when the patient received IL-6, especially it, it is not indicated once the patient is ventilated. So, friends, what I want to say, from the inception of the disease at West Bengal or at India till the end of July, August, we have seen a major change in the concept of the disease pathogenesis, treatment of the disease, and the outcome of the disease. Outcome has really changed by giving two things: give steroid early, give steroid in moderate to severe doses, recognize cytokine storm early, treat the comorbid condition, and give them adequate anticoagulation, and treat the patient at home if possible. And there was definite guideline when to discharge that came in the month of end of August. So the patient was admitted and used to get discharged within 7 to 10 days. So the bed scarcity was not very severe. And government of West Bengal has taken the policy at that time that each and every hospital should contribute 15 to 20% of their total bed for COVID patients. And that really works. One of our building was totally separated for dedicated COVID unit. And there was a definite area for donning and doffing. Government has also taken two major hospitals, Calcutta Medical College and Sagar Datta Hospital, as an entire COVID hospital. Then we have seen in between that initially we thought that COVID, it causes pulmonary symptom, okay. It produces hypoxia, it produces acute lung injury. But we have seen a lot of patients coming with diarrhea, which are RT-PCR positive. Then the concept of GI COVID comes. Patients of COVID developing encephalopathy, which cannot be explained by any imaging or by any electrolyte disturbance. So then the term of neuro-COVID comes. So we realize from August onward that COVID is a multi-system disease which produces a prothrombotic state in the body, and it can involve any organ. I have seen patients of COVID presented with pancreatitis, presented with encephalitis, presented with severe diarrhea, and each and everybody has seen COVID presented with hypoxia. Now, the next thing which came from the month of September, October, November, eh, from each and every person, each and every patient, Doctor, whether I'll vaccinate myself or not. This is not COVID vaccine. The concept of adult immunization was reinforced during the COVID era. As we all know, API has given our directive of adult immunization after the age of 50. Give pneumonia vaccine, give influenza vaccine. So initially, there was a dilemma whether we'll give or not, will not give. Now we all know we should vaccinate the patient, whether the patient is having had COVID or not. Now, in the month of December and January, first week, I am facing lot of questions from our patient. When the COVID vaccine will come, how safe it is, whether we'll take or not, and how much it is effective in preventing infection. What I can say, friends, that as we all aware that by 13th of this month, we are launching 2 COVID vaccine in India, and I always encourage everybody to take COVID vaccine as per government directive, because as you all know, if you suffered from COVID, the immunity that you have only lasts for few months, maybe 3 months or 4 months. So vaccination is recommended for COVID vaccination is recommended for each and every healthcare personnel to protect himself, as we have already lost more than 1,000 of our colleagues during this last 9 years battle.
Dr. Banerjee, can you sum up now?
So we had a tough time in the year 2020, and this 2020 teaches us a lot. But still I can say we only know the tip of the iceberg of the total disease process in future. Hope we'll overcome this tough situation, and we shall overcome. That's all. Thank you.
Dr. Banerjee, thank you very much for walking us through your personal experience since the early days of COVID in Kolkata. So may I ask you just one question? What is your protocol about anticoagulation? Do you give in a prophylactic dose? Could you give in a systemic anticoagulation? And how do you decide which patient will get what dose? And how long do you continue anticoagulation? Dr. Banerjee, you are muted. Can you unmute yourself? Dr. Banerjee, can you hear me?
I think we'll bring him later on. Sorry.
I think we'll go on to our next speaker, Dr. Manish Bansal. May I have the introductory slide, please? Yeah, Dr. Bansal is a cardiologist from Medanta, Medicity, Gurgaon, and he has an experience of more than 20 years. several publications in national as well as international journals. He's an active member in several regulatory bodies as well. And presently, he's Director, Clinic and Preventive Cardiology, Medanta Medicity, Gurgaon. Bansal, your experience, please. Over to you.
Yeah. I'll just share my screen once this has been taken off. Okay. Good evening, everyone. First of all, I would like to thank Dr. Parthasarathi Bhattacharya for inviting me to participate in this very important meeting. And it is indeed a privilege for me. So thank you for that. Now, as Dr. Banerjee talked about his experience of dealing with COVID over last 8-9 months, COVID has been a big learning for all of us, regardless of the specialty. And in fact, both as a clinician and as a person, at several levels, we have learned so many things from COVID. So I'll share what we as cardiologists have learned from COVID. Now, we know COVID is primarily a lung disease. When this pandemic initially broke out, there was a lot of concern about being flooded with cardiac patients, and there was anticipation that the whole hospital will be full of patients having cardiac complications. But over the last 8-9 months, we've realized that COVID-19 probably does not cause that much cardiac morbidity or mortality as we were anticipating. So, how a cardiologist can get involved in a patient who's got COVID-19? First of all, we know that patients who already have cardiac diseases, they are at higher risk of having COVID-19 infection, and also are at a greater risk of developing more severe illness. This, in fact, is the major reason or major mechanism which brings COVID-19 and cardiologists together. But apart from this, COVID-19 itself can lead to several cardiac complications. I will talk about the important ones. Then another common scenario is that the patient presents with an acute cardiac illness, such as acute myocardial infarction, and COVID-19 status is not known. And then we are in a dilemma whether to proceed with the treatment of that patient, invasive treatment in particular, and how to go about it. That's actually been a very important challenge facing all the cardiologists. And finally, as the months have passed, we are now increasingly dealing with patients who are having various symptoms after having recovered from their COVID-19 infection. So COVID-19 can cause several cardiac complications. These are some of the important ones. Myocardial injury is amongst the commonest, which is defined as rise in cardiac troponins above the normal level. Since this threshold for definition of cardiac injury or myocardial injury is quite low, troponin has to be higher than the normal value and at high sensitive troponin to label this as myocardial injury. The prevalence of or incidence of myocardial injury is going to be, I would say, overestimated compared to its practical significance. There are several mechanisms through which myocardial injury can occur in COVID-19. Most common is either systemic inflammation or myocarditis due to viral invasion into the myocardial tissue. But it can also occur because of myocardial oxygen demand supply mismatch, which is common in these patients who have tachycardia, hypotension, and hypoxia. Acute coronary event can also occur, but it is not that common as it was believed to begin with. And then iatrogenic myocardial injury can also occur because of various drugs that are used for treating COVID-19. Then acute coronary event, as I mentioned, has not been that common. The mechanism through which it can occur are either plaque rupture due to inflammation or increased shear stress, or it may be because of myocardial oxygen demand supply mismatch in a patient who already has significant obstructive cardiac coronary disease, which has not been symptomatic. Then thromboembolic complications are perhaps the most common vascular complication of COVID-19, as Dr. Banerjee also emphasized again and again in his talk. Patient can also have heart failure, arrhythmias, and several other complications. So, coagulopathy in COVID-19 can present in many different ways. It may be totally asymptomatic. It may uh, result in lethal complications. This is one patient, a young patient, 37 years old gentleman, admitted with COVID-19. He did not have any symptom to suggest pulmonary embolism. He just underwent CT chest for evaluation of his lung disease, and CT chest showed non-massive pulmonary embolism. Echo was normal. There was no evidence of deep vein thrombosis. So this was a milder form of pulmonary embolism. On the other hand, this patient had massive pulmonary embolism. And as we can see in this echo image, the echo image quality was not good because the patient was obese, but we can clearly make out something floating here in the right ventricle, which was a mobile thrombus. So this patient eventually succumbed to his illness. Then number of studies which have looked at pulmonary embolism and deep vein thrombosis in COVID-19. This meta-analysis was published just a few weeks back and included 27 studies with more than 3,300 patients. Several important findings emerged from this meta-analysis. First is that overall, pulmonary embolism occurs in 16-17% patients of COVID-19 and roughly 15% patients have deep vein thrombosis. Interestingly, DVT was found in only 40% patients who had developed pulmonary embolism, which means that in many of these patients, pulmonary embolism occurs because of in situ thrombosis rather than being true embolism. The incidence of pulmonary embolism was expectedly higher in studies in which CT pulmonary angiography was performed as a routine. And in these studies, roughly 30% patients were found to have pulmonary embolism. So this actually should be the true incidence of pulmonary embolism in COVID-19. And example which I showed you, the first example, also belongs to this category where CT detected incidental pulmonary embolism. Then an alarming finding about pulmonary embolism in COVID-19 has been that even those patients who have received prophylaxis anticoagulation, 16% of them were found to have developed pulmonary embolism, which is actually worrisome. Now, pulmonary embolism and deep vein thrombosis are one form of coagulopathy that occurs in COVID-19, but it can present in several different ways. So here is one example. This was a 68-year-old male hypertensive smoker, developed fever and sore throat 1 week back. At that time, he did not seek any medical attention. But then later, 1 week later, he presented with embolism to right great toe. When he presented, he was found to be COVID-19 positive. His echo showed this mobile mass in the left atrium. This could be myxoma, but more likely this was a thrombus. Myxoma usually is found in relation to the interatrial septum and has a totally different appearance. In this patient with this setting, it was highly likely to be a thrombus. Now, COVID-19 and coagulopathy also has been very mysterious in several other ways, especially the mechanism, why it occurs. Now, unlike sepsis, in which DIC is the commonest mechanism of coagulopathy, in COVID-19, it is more of inflammation and vascular injury, direct vascular injury, which leads to thrombus formation rather than DIC. So the coagulation parameters are not that much deranged as the extent of thrombosis is in these patients. And that is also the reason why many patients with pulmonary embolism do not have DVT, as I showed you in the previous slide also. Also, more of more often these patients have peripheral pulmonary embolism rather than central, as I showed you in the example. DVT is less common, and many patients who have died because of COVID-19 and underwent autopsy, they were found to have pulmonary microthrombi. So all this suggests that in situ thrombosis because of vascular injury and inflammation is the main driver of coagulopathy in COVID-19. Now, all the guidelines currently recommend that every patient who is hospitalized because of COVID-19, whether in ICU or in a ward, should be given VTE prophylaxis. The standard dose of enoxaparin 40 to 60 milligram subcutaneous OD is recommended for prophylaxis in these patients. The patients who are sicker, in them, some guidelines have recommended use of intermediate dose, that is between prophylaxis and therapeutic. And the patients who develop thrombotic complications, in them, obviously, we'll have to use therapeutic dose. But the protocol for treating these patients for prophylaxis of thrombotic events after discharge has remained quite debatable. Some studies have shown that these patients remain at high risk of thrombotic complications even after discharge, but many other studies have shown that the risk is not higher than any other patient who would be having the same clinical profile. So all the guidelines currently recommend that routine venous thromboprophylaxis after discharge is not recommended in COVID-19 patients. Only those patients who are at high risk of developing VT because of their clinical features, they should be treated. And for that, rivaroxaban 10 milligram OD is the dose that has been recommended. Now, after coagulopathy, the second most common complication in COVID-19 has been myocardial injury. Studies have shown that it occurs in roughly 7 to 17% of the patients who are hospitalized because of COVID-19. The incidence is much smaller in those who do not require ICU admission as compared to those who require ICU admission. Patients who die obviously have much higher incidence of myocardial injury. And myocardial injury, as expected, is associated with all other forms of worse outcomes, ARDS, mechanical ventilation, arrhythmias. This is because myocardial injury in COVID-19 is a manifestation of seriousness of the illness rather than primary myocardial disease itself. So more severe the COVID-19 disease, more severe is the systemic inflammation and hemodynamic perturbations which lead to myocardial injury. The true coronary event or primary myocardial disease has been less common, as I mentioned in the beginning also. In fact, at the time of initial spread of this pandemic through various countries and different populations, one was anticipating high number of MIs, both because of possible COVID-related coronary events, direct coronary events, as well as worsening of cardiac illness in patients who already had cardiac disease. But everyone was surprised within first 2 to 3 months of this pandemic that the number of STEMIs and ACS had actually gone down. This was first alerted in the newspapers in Europe and US in the month of April last year. But then subsequently, so many other studies have shown that number of ACS have decreased by 40 to 50% in different countries and populations. Many theories have been forwarded to explain this decline, uh, including low level of air pollution, which must have contributed to this definitely. Then low level of stress because people were now staying at home and not going for work, which would be associated with a lot of stress. But the most important reason why the numbers have decreased has been fear among the patient's mind of getting infected with COVID by coming to hospital. So patients chose to stay at home rather than coming to hospital, and that has been the main reason why incidence of ACS or STEMI at major hospitals has gone down. This has been shown in studies from India also. This is a study which was published from Chennai, included uh, patients who were hospitalized during the 3 month period last year, March to May, and the investigators compared the same with the previous year. And they found that there was almost 40 to 50% decline in all ACS or STEMI cases. And the patients who presented to the hospital, they had much longer time from symptom onset to hospital presentation. In 2019, it was 8 hours, which increased to 24 hours in 2020, which means that there was a lot of hesitation in the minds of the patients for coming to hospital and seeking treatment. And as a result, there was numerical increase in hospital mortality also, although this difference was not statistically significant because the numbers were very small. Now, there's another study, very large study, just completed, and it is under publication right now from India, multi-centric study, which has shown that number of ACS and STEMI presentations in major hospitals have certainly decreased. At the same time, numbers at the smaller hospitals has increased, which again shows the same thing that most of the major hospitals were converted into COVID hospitals in most of the cities. So patients prefer to go to smaller hospitals for their treatment, and uh, that was the reason why we saw less number of patients coming with ACS. Now, when patients present with ACS, their diagnosis and treatment has also been challenging because we cannot rely on troponin as a marker of coronary related myocardial injury in these patients because myocardial injury is otherwise also common in these patients. So we can't rely on troponin. We can't rely even on ST elevation. And this was, we have all experienced this, and this was also seen in this case series from New York published by Sripal Bangalore et al. In NEJM. 18 patients were included. All had ST elevation, but only 8 of them had MI. Now, one good thing was that the patients who had regional wall motion abnormality, most of them had MI. There was no patient with regional wall motion abnormality who had non-coronary myocardial injury or non-coronary ST elevation. So, regional wall motion abnormality may be a good indicator towards the presence of myocardial infarction as the cause of ST elevation. Another interesting observation from this case series was that the patients who presented with myocardial infarction, they had lower mortality as compared to those who had ST elevation in absence of myocardial infarction, which means that ST elevation without myocardial infarction occurs when there is more serious and global myocardial injury caused by COVID-19. However, although I mentioned that regional wall motion abnormality is helpful in diagnosing these patients, but in many cases that is also not reliable. So here is one example. This was a 46-year-old lady, no comorbidities. She had fever with cough for 2 days, roughly 10 days back, treated by a local physician, improved, but then later she presented with chest discomfort and breathlessness for almost 15-16 hours. This is her ECG. It shows subtle ST elevation in V1 to V3. But more importantly, there is marked prolongation of PR interval, which is another important finding in COVID-19. So here, PR interval was almost 280 milliseconds. And these are her echo images. As we can easily make out, there was apical hypokinesia, clear cut, unmistakable, but she had normal coronaries. So most likely she had Takasubo syndrome or stress cardiomyopathy, although we do not have her recovery images here. This is another lady, 77 years old, hypertension, diabetes, hypothyroidism, recent TIA. She developed COVID-19, recovered 2 weeks later, presented with fever once again. So she was being evaluated, but in hospital, developed chest pain and rise in troponin. As we can see here, echo again shows wall motion abnormalities involving apex. EF was hardly 35%. She underwent angiogram, which showed triple vessel disease, but it was diffuse disease, and given her age, it was treated medically because LAD had highly calcified lesion. Interestingly, when echo was repeated 10 days later, again, wall motion abnormalities had disappeared. So in this patient also who had triple vessel disease, significant TVD, this particular episode of myocardial dysfunction and fall in EF was probably something similar to Takasubo syndrome. So basically, this again tells us that diagnosing acute myocardial infarction in these patients may be quite challenging, even with echo. Even when we diagnose MI in these patients, treating them timely and effectively remains challenging because on one hand, we need to act fast to ensure good clinical outcomes, but at the same time, we also have to take care of minimizing exposure to healthcare worker and contamination of equipment, especially if we are planning invasive treatment. And this again has been a big problem, has been shown in many studies. This study from Hong Kong showed that when COVID-19 pandemic occurred, all time parameters in STEMI management were significantly prolonged. Like door to device time was increased, cath lab arrival to device was also increased. And the net result of this can be seen in this large study that included more than 30,000 patients from Wuhan province in China. As we can see, timely reperfusion was significantly reduced after this pandemic occurred, resulting in increased mortality. So these are sobering figures, and we keep experiencing it every day that delays happen even even though it's been 8 9 months and the systems have become much more efficient, but delays still happen. Arrhythmias can also occur in COVID-19. All type of arrhythmias can occur. Tachycardia is obviously common. All forms, atrial fibrillation, flutter, supraventricular tachycardia of other type, mainly because of the hemodynamic disturbances and metabolic abnormalities. But more interesting is bradycardia or other types of bradyarrhythmias that happen in these patients. And this is one example. As we can see, this patient has significant pericardial effusion and has features of tamponade. We can make out RV collapse in the first image, but heart rate is only 74. So this is paradoxical. A patient with tamponade is expected to have tachycardia. So this relative bradycardia is a very common finding in COVID. And a few months back, cardiologists from GV Pant Hospital in Delhi published this series of 7 patients who had presented with more severe bradyarrhythmia in the form of complete heart block, frank complete heart block. So this again suggests high incidence of bradyarrhythmias in COVID-19. And finally, now that the epidemic has been 8 9 months old, we are seeing more and more number of patients who are coming to us with various symptoms after their COVID illness. We looked at our own data of nearly 100 patients and found that most common reason for presentation was palpitations and persistent fast heart rate, which was seen in roughly 35% patients. Breathing difficulty and chest pain were the other common reasons why patients presented to us. But interestingly, most of the evaluation in these patients was normal, except sinus tachycardia. Echo was normal, including even strain imaging. So there was no apparent cause, there was no hypoxia, normal PA pressure. Now, a very recent study from US published in JACC imaging shows that maybe this is because of myocardial edema, which we are not able to pick up on echo. In this study, 26 patients who recovered from COVID-19 and presented with cardiac symptoms, mostly palpitations, were evaluated. And it was found that 58% of them had abnormal CMR findings, even though they had recovered from COVID-19 6 months back. So maybe residual myocardial edema, which can be picked only by MRI or more sensitive techniques, is the reason why these patients continue to have tachycardia and other symptoms even after their recovery from COVID-19. So to summarize, COVID-19 is primarily a respiratory illness, but underlying CV risk factors and CVD increase the severity of illness in these patients. And that is the most common link between COVID-19 and cardiac disease and cardiologists. Apart from this, COVID-19 itself can cause cardiovascular complications, especially in those with severe illness, severe underlying illness, severe respiratory illness. Myocardial injury and thromboembolic events are the two most important cardiovascular complications. And residual subtle myocardial edema is a common finding in patients presenting with post-COVID cardiac symptoms. Thank you.
Thank you, Dr. Bansal, for taking us through this cardiologist point of view of COVID-19. So before we move on, can I ask you 2 questions? One is regarding that very difficult to share managing a patient with existing changes. Could it be, clinically fixed with Takashubho? So do you subject all your patients to coronary angiography just to rule out a coronary disease? How do you handle such a patient?
So in patients who present with acute myocardial dysfunction with regional valve motion abnormalities, there is no option but to subject them to coronary angiography. Because although CT and MRI can give us some clues, CT coronary angiogram can detect it, but performing CT angiogram in patients who have tachycardia is challenging. CMR will be equally challenging. Coronary angiography will be the simplest, especially in sick patients. So we end up doing coronary angiogram in all patients who present with regional wall motion abnormalities and symptoms suggestive of ACS.
The other thing is that in literature we see a lot of events of sudden cardiac death, COVID and immediate post-COVID period, even at home. So, what is your personal experience? How many patients have you seen succumbing to sudden cardiac death, and what
So
do
in
you do? Is it myocardial dysfunction, or most of them are due to PE? What is your opinion?
So in patients, we have at Medanta, COVID care team has treated more than 2,000 patients with COVID over the last few months. Out of these, 2-3 patients developed sudden cardiac death in the hospital itself. The reason in those patients was that they had significant coronary artery disease, which was about to be managed, could not be managed in time because of COVID-related issues, and they had sudden cardiac death. So maybe the sudden cardiac death in these patients who have died at home or anywhere is because of underlying coronary disease, which did not get diagnosed in a timely manner. That, to me, appears to be the most likely reason.
Thank you.
Thank you.
Arthur, can we move on to the next speaker?
Yes, sir. Yes, sir.
So I think it is my privilege to invite Dr. Adil Pratham Dotto, who requires no introduction to this audience, actually audience all over here, an eminent nephrologist and very good friend of mine. So we are eager to hear from Arup regarding nephrologist take about COVID-19. Arup, over to you.
Okay. So thank you very much, Dr. Bhattacharya and Partho, of course, to invite me here. I was a bit skeptical initially because I didn't prepare slides, and then Partho told me that it's okay to speak without slides. So so like Dr. Narayan Banerjee, I'll be just speaking about my experience overall. So can we have the video on? I think I'm not. Yeah, okay, fine. So I had asked Dr. Bhattacharya to send me a few questions that generally cross people's mind in relation to kidney and COVID. So he sent me a set of questions, and I have summarized those questions actually. So basically, I'll be discussing under 3-4 headings. First question is obviously that how does COVID affect the kidneys, and what is the renal experience from there? And this is number one. Number two is what is our experience with the dialysis patients, where we have got a captive people, you can say, that who are on maintenance dialysis and who have to come to the hospital 2 to 3 times a week, and we have a large base of such patients. How have we managed those cases? And thirdly, most importantly, what have we done with our transplant patients? By transplant, there are again 2 categories. One is the existing transplant patient, which is a large number again, and what have we done with the transplant during this period? So I'll be taking these issues one by one. So coming to the first part, how does COVID affect the kidneys? So as you know, now the data says that during the pandemic, if you have 100 hospital admissions, about 1/3 of them will be having some kidney issues. I'm not meaning the dialysis transplant patients here. Even somebody else who don't have all these problems, they are admitted with COVID, severe COVID, requiring hospital admission, you can expect that 30% will be having some kidney-related abnormality. Now, having said that, we haven't seen so much of AKI, the COVID-related AKI requiring dialysis. This is, although there is enough literature on that now, somehow our experience is slightly different. We haven't seen COVID AKI to that severity. Now, the definition of AKI can be, somebody's creatinine rising from 1.1 to 1.6. That is also AKI. So if you take all this, then, that makes it 35, 37%. But somebody not having comorbidities, getting COVID only, and getting dialysis because of COVID-related AKI, that has been really rare in our experience. But we have seen a lot of patients, really a lot, and that we cannot be counted, patients who had existing CKD, they had hypertension, diabetes, obesity, whatever, all the works. And they have creatinine in the range of 2, 3, 4, 5, like that. They are not yet on dialysis, but there are known chronic kidney disease patients who are on conservative treatment. They get COVID, and when they get admitted, they deteriorate their renal function, and they are often require dialysis. So this has been a large brunt with us. So how does COVID affect the kidney? Now let us discuss a bit of the pathology. A large majority will be pre-renal versus acute tubular necrosis, as in any AKI. There have been cases of collapsing glomerular nephropathy, which is, it is something like a glomerulonephritis with proteinuria and very fast decreasing renal function. There are cases of that, and autopsy cases, and also people who have done biopsies in such cases. There has been incidences of TMA, thrombotic microangiopathy. There have been medication issues also, because people at one point of time were thinking that remdesivir can be a problem with the kidneys, although our experience doesn't say that. But there were some issues about remdesivir causing AKI, not too much. And I think it is of anecdotal, but it's of interest to me, is that vitamin C causes oxalate nephropathy. This is something which not everyone will be knowing. So I have been a little easy on the vitamin C. I have seen patients taking megadose of vitamin C and going on taking for 2 months, 3 months, even after COVID. That's something which I personally avoid, because it can give rise to oxalate nephropathy, the too much of vitamin C. And this has been reported also during this COVID thing. So in summary, by and large, pathologically, it is either pre-renal or ATN. And you have some incidences of collapsing glomerulonephritis and thrombotic microangiopathy and certain medication issues. So this covers the entire COVID-related AKI. Now, I will say this again, that for a normal person without comorbidity, for a young, fit individual with COVID, getting AKI requiring dialysis has been extremely rare in our situation. Probably I have not seen that. But I have seen a large number of patients who have elderly with diabetes, hypertension, and existing chronic kidney disease dropping their renal function and going into dialysis. That I have seen plenty lot. So that is with how the, okay. Now, one related question here is that, does the virus involve the renal parenchyma? This is a very important question. Like we know the virus involves the lung for sure. So that's the main thing. But does the virus involve the kidney parenchyma? So this question has not been answered clearly. There have been few autopsy studies, and they have tried to see that by electron microscopy or by immunohistochemistry. And the results say that it is possible, but it doesn't happen all the time. So it is kind of rare, but it is possible to have the virus going into the renal parenchyma as well. So that is with the AKI, the first part. The second part is, what is our experience with the dialysis population? Now, as Dr. Naran Banerjee was saying, that we can easily, I actually quite support his, his division of the phases, like phase 1, phase 2, and phase 3. In phase 1, when it really came, we thought it was not going to come here, but it suddenly came. Our major problem in all the hospitals were that we have got a maintenance dialysis population, which there are 240 hospitals in Calcutta. And between the two hospitals, we have about 300 patients who are 350 patients on maintenance dialysis. So these patients are on regular dialysis program. They're not admitted. They were admitted maybe at some point of time, but now they are continuing maintenance dialysis as otherwise fit, healthy individuals, but they come to the hospital 2 to 3 times a week, and they get the dialysis as an outpatient basis, and they go back. So what do we do with this kind of group? So in the month of March, April, immediately the problem came with the PPE. Our technicians were kind of reluctant to dialyze, and we did not have a protocol for testing. And I think testing, as Dr. Banerjee said, testing was not easy at that time. You just could not test anybody. And I also personally felt that, what are we going to do with the testing? Supposing somebody is positive, how are we going to handle it? Segregation, you cannot just do it, out of the blues. We may not be having that amount of space, that amount of machines, that amount of personnel. So we sat with the technicians and the nurses. We gave them PPE as much as what was possible at that particular thing. From May, June onwards, the PPE problem was not there anymore. So people are freely using the PPE. So all technician nurses had a full PPE in the dialysis unit. We were not testing our patients on a standard basis. We would not test unless they had symptoms. But we had a low threshold for testing if the patient had any symptoms. Somebody having a little spike of fever, or we had a questionnaire given to them which they had to fill up before every dialysis. And if there was a spike of fever or any symptom, we would test them. But of course, the turnaround time used to be a problem. As you know, that the results were not immediately available. We had to send somewhere and the result would come either on that night or on the next day. So what will you do with a patient who has come, a dialysis patient who has come, and he has some minor symptom, which doesn't look very much like COVID, but again, sitting at that point, you cannot rule that out. Doing a CT scan and spending a huge amount of money just for screening was also a bit too much, we felt at that time. So that initial phase was a bit difficult for us, but then we managed and then things became easy because the testing became easy. So out of this total 350, we have roughly about 12% of our patients had COVID up till now. Now, I see in the last 2 months, touch wood, I mean, I keep my fingers crossed as I say that this number is actually coming down in our dialysis population. We so far had about 45 patients who had, which comprises about 12% of the dialysis population who had COVID. And of that, now you can understand that these are the sickest group of people. They are probably elderly, they've got diabetes, hypertension, a large majority of them, and they probably have cardiac disease. They may be having other comorbidities also, malnutrition sometimes, other lung disease also. You know the works. So out of the 45, we lost 15, which means 1/3 was a mortality, which I think was quite high. I mean, in this time frame. But then that is the general picture all around the world, because this is the sickest group of people. And for drugs, I would say when we kind of admitted them, these patients are on heparin already every alternate day during their dialysis, and the average dose there is about 5 to 10,000 units. So
Dr. Dotto, can you hear us?
on the other days we have. Is it okay? Can you hear me?
But your face is rotated.
Can you hear me?
Yeah. I can hear you, but your image is rotated. Can you just adjust?
Okay, right. I know. Okay.
Okay. Yeah, you can carry on.
Okay, now, right. So suddenly the connection went off. Can you hear me now?
Yes.
Yes. Okay. So we have also given remdesivir. There were certain issues about remdesivir, whether that to be used in dialysis patients or not. But we used them in the sickest of our group when they were not improving by the usual things. And we were not worried about the kidney thing at all, because you can't harm their kidneys anymore. They are already on dialysis. So I was fairly free to use that. So that is the experience with the dialysis patients. Tell me if you are unable to hear me. I'm not sure if I'm audible.
You are audible to me very well.
Okay, fine. So now that brings me to the last part, and that is what do we do with our transplant patients? Now, at the beginning of the pandemic, obviously, like everyone else, we were very, very kind of, you can say, afraid about what will happen if a patient is on immunosuppression. Because when you do the transplant, you actually give the highest dose of immunosuppression possible. In Bengali, we say that immunosuppression is chubiye rakhar moto. So we are afraid that if we do a transplant with that high level of immunosuppression, and someone contracts COVID, be it in the hospital or when he goes back home, then what are you going to do? Obviously, you have to drop the immunosuppressant to some extent. Steroid is just one component of the thing. We'll, of course, keep the steroid. Or what about the tacrolimus? What about the mycophenolate? And you have given ATG or you have given rituximab, so all that works. So, that has got an effect in the body. If you are stopping today, it doesn't mean that the effect is completely gone tomorrow. Now, if you drop the immunosuppression too much, then the kidney can reject. So that brings in another level of problem. You do the transplant to give them a kidney, but if you have to drop the immunosuppression too much for COVID and if the person loses his kidney, then there is nothing worse than that. So across the world, I think transplant activity came to a stop when each country was on their rise in the COVID cases. But in the next few months, we understood that it is possible to do so. Some hospitals started doing, and we have also restarted, but we have restarted only recently in the last about 6 weeks or so. Now we have started transplant and we are doing the usual thing now. Now the cases have come, we have established protocols for that. We are getting these patients about 5 or 6 days earlier the transplant. Generally we admit them 1 or 2 days prior to transplant. We admit them 5-6 days earlier and we ask the recipient and the donor to stay in the same room. And we do COVID test 3 times in the previous week. And we also do a screening CT scan about 7-10 days prior to the transplant. We are just very sure that they are in a controlled environment, and the nurses who are put to duty are probably the nurses who have had COVID already and who have come out of COVID already. So generally we try to do that as much as possible. So the transplant activity was completely stopped, and it has by and large restarted now. Of course, not to the same extent, but it is more or less started. Now, so what is the experience with the patients? So I had in these 9 months, total 42 patients of the patients who are under my follow-up transplant done in our hospital. 42 got affected with, which is a large number, but I can't tell you the exact number of transplant patients on follow-up because not everybody is alive or not everybody is kind of following up here. So we don't have that exact number, but this will be a couple of thousands at least. So about 42 were kind of affected and 7 could be managed by home isolation. So they were not too bad and we could understand by phone. We are doing video calls. And as Dr. Narayan Banerjee said, this is also a learning that we are doing webinars and we're doing video calls. It is possible to do much of your work this way. So 7 could be managed at home and they were okay. And the rest 35 were admitted and we lost 3 of them, including a colleague of mine who was also a transplant patient who are undergone transplant in our hospital. We actually lost him because of lung fibrosis. And you can understand that this disease is kind of unpredictable. You don't know what happens to whom. He looked pretty all right at that time and he went home all right, quite all right. But in about 3-4 weeks later, he got readmitted with pulmonary fibrosis symptoms. And we just couldn't do anything more after that. And he went on a ventilator and just could not come out of it, ultimately. So what do we do? So 3 deaths out of 42, which I'd say is less than 10%. And I think I'm, so far, again, fingers crossed, quite happy with this number. Now, what do we do when a transplant patient comes? So again, we have a very low threshold for admission. We would try to judge when the phone call comes. We will try to see him on the video. And we have an extremely low threshold to advise admission. And when we take them in, typically we stop the mycophenolate. Generally they're follow-up patients, so they are already on a maintenance dose. So dose is not very high in any case of tacrolimus. The mycophenolate dose is typically about 1 gram to 1.5 grams a day. We stop the mycophenolate completely. We continue the tacrolimus and we up the steroids. So the typical maintenance dose is about 5 to 7.5 milligram. If the patient is not very symptomatic, we'll keep about 20-25 milligram, or we will change either to dexamethasone or to solumedrol, depending on what we have liked at that particular point of time. The pulmonologists, they prefer solumedrol. We are okay with dexamethasone as well. So we would give that. And again, I have used remdesivir in about 60% of these cases, because if we think that they are not getting better in the first 2 days, 3 days, or there's any sign of deterioration, we have given remdesivir. And people who have taken remdesivir, they feel that the drug is making a difference, whatever be the controversy around the drug and whether the ICMR trial and whatever you say, the WHO report. They were kind of confusing. If you ask any doctor friend who took remdesivir, he will vouch for it. I'm pretty certain about this. And seeing my colleagues saying by this, so we have given remdesivir freely here also. And I would say about 60% of the transplant patients got remdesivir, because again, you cannot take a chance in these cases at all. And we have the anticoagulation here, I think half was low molecular weight heparin and half was the standard heparin. So no particular issues there. We have by and large used a prophylactic dose. Sometimes we have given a therapeutic dose when we felt that the shortness of breath was not really decreasing, and we did not have a very clear-cut way of distinguishing between what is happening, whether so much of is inflammation or it is thromboembolism. And no test is kind of definite. I mean, you can do CTPS, you can expose them to dye, and also sometimes this becomes impractical to me. Must have a more practical heuristic approach. So what we have given, we begin with a, depending on the symptoms, we would begin with a prophylactic dose, and if he's not doing well, we'll just go to the therapeutic dose, and then you just take it from there. So majority would improve eventually. If not, then we'll go for the other further investigations. So by and large, I'm happy with the transplant patient's experience. I am a little worried about if a dialysis patient gets this, because the mortality is 30%, is 33%. And that is all over the world. It is like that. So briefly, that is my experience. So I can take questions.
Thanks, Dr. Dotto, for giving us very practical suggestions about dealing COVID-19 in the nephrologist point of view and the dialysis and RRT patients. Now, before I ask any other to ask questions, you said that you stopped mycophenolate initially. Is it because of the fear of cytopenia, particularly lymphopenia?
Yeah, okay. So the background of this is whenever a transplant patient gets admitted with any kind of sepsis, so generally we lower the immunosuppression. You have to understand the concept of something what we call as a net immunosuppression. So let's say when you're doing transplants, this is the amount of immunosuppression that is going on. So with time, that immunosuppression is actually coming down. So, and on a maintenance patient is probably having this much of immunosuppression going on. Now, in the face of sepsis, you have to decrease that further. So that's the background idea. And there are three drugs for that. One is tacrolimus, one is steroid, and one is mycophenolate. So in most sepsis situations, we up the steroids nowadays. So you generally take off the mycophenolate. Cytopenia is, of course, one of the problems there. But this actually stems from the usual practice of taking off mycophenolate in any septic condition when a transplant patient presents. That's the usual practice. So we have just extended that to COVID also.
And another aspect is that most of your patients who are undergoing RRT or post-transplant patients are immunosuppressed. Now, in immunosuppressed patients, this seropositivity can last for a longer time, though not necessarily they are infected to others. But we have seen those patients have an RT-PCR positive beyond 4 weeks or so. So,
yes.
In such a situation, assuming that they may be infective to other immunosuppressed patients, how do you handle them when they come for a follow-up dialysis?
Yeah, so what we have, right, I can understand. This was a big problem for us also, although there were some directives actually from places like Maharashtra, Bombay, where they had a huge number of cases. And this was an issue about the dialysis cases. Now, what do you do with them? They are kind of positive for 6 weeks. One of my colleagues, somebody who works with me, was positive for 6 weeks. Now, he was a normal person, but if a dialysis patient is positive for 6 weeks, so, like a large number of dialysis patients become positive and they stay positive. So where do you dialyze them? So the policy that we took was that we had a separate room where we were dialyzing the COVID cases. And even after discharge from the hospital, we continued to dialyze them there for another 2 weeks period. And so long they were kind of positive, we although they were clinically okay, we dialyzed them together with the active patients who were in the hospital. We treated them as kind of positive, but a low positivity. And we took them in the main unit only after they had become negative. But again, there is a fallacy in this statement. If, let's say, the epidemic in Calcutta was not ebbing, and supposing we had something like what Delhi had or what Bombay had, what would you have done? I don't think we could have stuck to this policy. We would have had to take them inside the main unit. So it's all a question of the number that you have in hand and whether the number is on the rise or whether the number that is kind of falling. So no policies are exact. This is what I have learned. There is nothing exact here. There's nothing right or wrong about it. There is what you think best at this particular point of time. You have this unit, you have this amount of cases, and you have to manage them somehow. So you do what you think is best at this particular point of time. 2 weeks later, your policy may be completely different. As we have completely done this adaptation right from the month of March, and I'm sure all of us have done that in their own way, and we are still now going on adapting, like depending how the situation, now our COVID beds have come down. So there was a time, let's say 2 weeks back, we were getting cases very easily. I mean, so now the main tension is when I get a call. It has been like that always, I'm sure with all of you also. The main problem was not the sickness of the patient. We know we have a handle on that. We can manage it. The problem was to get a bed. Our ICUs were full, everything was full. So then about a month back, the beds became easy to get. And now the hospital, the COVID areas have been shrunk. So now again, we are having a problem. If somebody calls, I may not be able to take them. So we are going on adapting depending on the cases that are happening. So in the dialysis also, the policies by and large, we are now dialyzing them in a separate room. But if the number increases, we might have to spill over. Hopefully that will not be required anymore.
We have two questions from the audience.
Right.
Professor Paul has asked. He has lost 2 patients of SLE and MAS on follow-up due to COVID-19, and they succumbed to renal failure. So
yes.
what advice? And second is, in the face of COVID-19, vaccines being a live virus vaccine, how far it is safe to recommend in autoimmune rheumatic disease in remission?
So let me take the second one. So I don't think I can really comment on that. But I mean, like, we have the same background for the autoimmune diseases. So I think your answer will be my answer only. So it's not clear, but probably the vaccine regulators and the vaccine scientists have not spoken anything against this, or they have not given a special caution that such patients cannot be used. So I think so far there is no directive specifically for these kind of patients. Probably everyone will come under the fold, and I'll be okay to do that. This is the second question. For the SLE patients, as I mentioned in the initial part of the talk, the people who had CKD and had COVID, obviously many of them have deteriorated and they have gone on to dialysis, and obviously they are the sickest of the people. Now here the main thing is, how do you balance that immunosuppression? So for COVID, which I found also, and I would like to hear all your comments regarding this also, this is only one thing in medicine, that an infective agent is being treated by immunosuppression. I mean, this is completely different. I mean, I don't see a parallel of this in the entire gamut of clinical medicine. If you have an infective disease, you treat with an anti-infective. You treat a viral disease, you treat with antiviral. That has always been the thing, and with a bit of supportive therapy. Here, an antiviral, it's a viral agent, or you're treating with something else completely. We don't have a specific antiviral, maybe remdesivir to some extent, but the whole thing is on the steroid and the other part. So that issue is there. How much you immunosuppress. In the process, see, the SLE patient, they are also again on a net immunosuppression. They are much like our transplant patients. They are taking immunosuppression for long, so their body is weak, obviously. They can get more infections. So if you increase the steroids, obviously you can also bring in another chance of infection. You may do some cytokine, you can handle that, but you can bring in a fungus, you can bring in some kind of a worse bacteria. That can always be there. That's the usual experience.
And there is there is a patient who is on dialysis and has contracted COVID and became negative subsequently. When can transplant be done?
Okay, so I think I will take it like this, that even if he's otherwise fit, and because there's no specific guideline here, you will go by the general fitness. If you find that he is otherwise okay, so of course I will ask you to look at the heart and lung very well once more. Obviously, you will not do it in the first 1 month, Beyond 2 months, I think there is a, I mean, it all depends how quickly he became okay. This is also an important thing. Could he be managed at home, or was he admitted? Was he very sick? Did he require ventilation, and did he come out of it? If such, then his general condition must improve to that point of taking the surgery. Transplant surgery takes about 4 hours at least. So you have to take it that. If his general condition is good, go ahead. After 2 months, I think it's okay to go ahead.
Thank you, Dr. Datta. Partha, I think.
Sir,
Thank you.
we have one more question.
Right.
So I would just quickly ask you.
Yes.
The question is, what should be the futuristic precautions that should be taken care of in case of a COVID patient with polycystic kidney? The patient went through remdesivir and immunosuppressants like tocilizumab.
Okay. So there's no specific thing for that. I would understand that the patient is not yet on dialysis. So, of course, COVID will have a brunt. And the fact that he required tocilizumab, which means he falls under the severe category of COVID. So there's no specific, and if he did not deteriorate his renal function, he did not go into dialysis, then it's good. So you just have to allow him enough time to kind of recoup. So there is nothing special to be done for this. So there is
Sir,
nothing
just
special that can be advised here.
okay. Thank you, sir. And there is just one more before we move on to our next speaker. And it is that, in fact, people are getting invasive fungal infections like aspergillosis in post-COVID lung infections. Is it true?
Yes. Yes. Yes, I have seen that in our hospital also. So you know what? Let me put it like this: if you do something, there's always a price to pay. Like if you are giving too much of steroids, you are likely to bring in some other kind of thing. So if it is, and fungus is there, we are all living within the fungal thing. So it is not surprising at all that some of these patients will invite the fungus. If he is already, there's got comorbidity, bad lung, you've given steroids for long and a high dose. So obviously this lung is ripe for getting all that. That's there.
Now, COVID-associated pulmonary aspergillosis. I think,
Yes.
Farouk, Dr. Datta, thanks a lot, and we'll move on
Thank
to.
you. Right. Thank you.
Shujit also needs no introduction. He's an eminent gastroenterologist of our city, and presently he's associated with AMRI hospitals. It's a privilege for me to invite Shujit to share his thoughts. Over to Dr. Shujit Chaudhary, please.
Okay. Good evening to everybody. Am I audible?
Yeah, absolutely.
Can you? Yes. Okay. Thank you, Abhijita, and thanks to Dr. P.S. Bhattacharya, my friend, to share some of my experience regarding the GI problem and liver problem in COVID infection. So, you know that COVID is almost at present, though it is predominantly in pulmonary involvement, but there is multi-system involvement and GI tract is involved. And we know the COVID receptor for the COVID is the ACE inhibitors, ACE receptors, ACE2, and ACE2 is amply present in the GI tract and also present in the liver, particularly in the cholangiocytes. So the COVID can affect the liver, COVID can affect the GI tract. The important aspect of GI involvement, that because the COVID has been found to be shedding in the stool, so there is you have to take care because of its infectivity. So the stool is an infective sample, and you have to that is an important for the infective part of the COVID infection. Regarding the GI symptoms, the GI symptoms varies from different non-specific symptoms like nausea, vomiting, but there may be some pain abdomen, and there may be diarrhea. So these symptoms varies from about 15 to 20 to 20, up to the 50% patients having the GI symptoms. And another important is the loss of taste and loss of smell. So this is very important, and it can be present. It has been found to up to 70% patients of COVID infections. But the the GI, another GI problem is that when we are managing the other disease, I will discuss about the problem of endoscopy. The endoscopy, you know that endoscopy, as COVID is transmitted through the aerosol, and when we are doing endoscopy, the aerosol is generated, and we are taking all the precautions to personally and all the healthcare workers for prevent this transmission. Even always at is recommend we are doing the procedures when the COVID test is negative. But in emergency situation and in a patients of COVID infection, if the endoscopy is necessary, then we have to take all the care for the endoscopic procedures. And my personal experience that though I am not regularly going to COVID ward, but sometimes we have to give the advice to my colleagues regarding the problem of liver and problem of GI tract. And a patient presented with massive variceal bleed and particularly from the gastric fundal varix. And we had to do, I did the sclerotherapy for fundal varix, and the patient was salvaged, patient recovered. Then the patient's problem of this patient was mainly of GI bleeding, not for of COVID, but the COVID infection was there. So no active management for COVID was required. Patient recovered. And so the other problem of regarding the liver involvement, you know, I mentioned that the COVID involved the cholangiocytes. These receptors are present in the cholangiocytes. So, but cholestatic features is not very common in COVID, but mostly it produces some amount of hepatitis. So it may be a part of the systemic inflammatory response. The liver is affected, and elevation of transaminase, particularly SGOT and SGPT, has been found to the tune of 15 to up to 50% of the patients. But rarely there may be elevation of bilirubin also. And these elevations is a factor to interfere that whether when the drugs for COVID, particularly tocilizumab and remdesivir, has been found to have some hepatotoxicity. And if so, it is recommended that you should monitor the liver enzymes when you are giving the therapy. And you should not give therapy if it is if the bilirubin is high, or if the SGOT, SGPT is more than 5 times the upper limit of normal. But mild elevation is not a contraindication. It has been found that even after therapy, the elevated enzyme is part of the COVID infection. It gradually becomes normal. But the most important problem of COVID is the liver disorder. Otherwise, acute liver failure has been without pre-existing liver disease. There are a few reports only that can produce acute liver failure when a patient has not having any pre-existing liver disease. But most important, the problem is that when we are managing the patients of chronic liver disease, particularly cirrhosis with COVID infections. And my personal experience is that I have lost few of my patients of decompensated, that is child C cirrhosis. And the mortality in the scientific literature, that mortalities can be as high as 60%. So 2/3 of the patients have died in case of advanced liver disease with COVID infections. So you have to be very careful when you are managing the patients of COVID with chronic liver disease, particularly cirrhosis. The problem is that whether you should give the steroid, whether you should give tocilizumab, whether you should give remdesivir. There is no guideline, but that is recommended that this steroid, really, if the patient is in a child's A cirrhosis, that is compensated cirrhosis, steroid use or dose can be given. You have to monitor the liver function test parameters. But very in advanced cirrhosis, definitely steroid, you should be very careful that whether can be given or not. Child C is contrary. And both about these other two drugs I mentioned, that tocilizumab and remdesivir, cannot be given in patients of child C cirrhosis. So you have to be very careful in patients of compensated cirrhosis, and if the patient is severe COVID infection, you have to monitor the liver function parameters. And if you feel that you have to, risk and benefit has to be judged, and then you have to give the therapy. Regarding the endoscopy, I have mentioned that the risk of transmission is very important. And the drug-induced liver injury. I've already mentioned that the many of these drugs which is not present that can produce liver mild elevation of SGOT and SGPT, that is liver transaminase activity may be high, but mostly with the therapy that it normalizes. But if it is going high, if it is very high, then you have to stop the therapy also. Regarding the other drugs, like that in patients of cirrhosis, if there is compensated cirrhosis, sometimes the patient may present with COVID infection, but there is apparently there is fatty liver and there is no history suggestive of liver disease, but there is compensated cirrhosis cannot be diagnosed easily. So you have to be very careful giving the lots of paracetamol or non-steroidal anti-inflammatory drugs. It has been found that NSAID and high-dose paracetamol can be detrimental in patients of compensated cirrhosis. Regarding the steroid, I mentioned that steroid has to be given, but we have to monitor. But those patients who are on steroid, many of our patients, like particularly patients with autoimmune liver disease, on maintenance dose of steroids, many patients of inflammatory bowel disease, they are on steroid. So if the patient is having COVID infection, and if you need the steroid dose has to be have increased. And definitely patients who are not been COVID, but it was recommended when the patients on steroid and their risk of this, they should not stop the drug, but you should try to reduce the dose. Regarding the immunosuppressions, many of our patients of inflammatory bowel disease on immunosuppressive therapy, you should not stop the immunosuppressive therapy like azathioprine or methotrexate should not be stopped. And it has not been found to be detrimental. And regarding the liver transplant patients who are on immunosuppression, as Dr. mentioned, that you have to reduce the immunosuppression if the patient developed COVID infections. You have to adjust the dose. Otherwise, it has been found that the patients who post liver transplant on immunosuppression, there is no added risk when they are acquiring COVID infection. So probably this is the immunosuppressive effect is beneficial for COVID infection in this group of patients. Regarding the transplant, whether it should be done or not, it has been but initial fear, but later there are a lot of the surgeons in the higher transplant centers, they are doing liver transplantation in this COVID area. Definitely COVID infection has been excluded by different tests, and then transplantation is done. It is not, cannot be. The another impact of COVID, what is happening, we are facing that there was a withdrawal of care. The patient were not coming, they are not follow up because of their care at home. And later part we are facing, and also it is in the literature that they are presenting with more complicated problem. So advanced cases, decompensation. So that is the main impact, and another is the economic impact. The patient's care and the investigation has been withdrawn, treatment has been reduced, withdrawn or suppressed, for which now the patients are suffering. So this is in a nutshell. I think I can give you the. So another important, just I want to mention the personal experience. One patient was admitted of hepatitis B cirrhosis, but very much compensated. The lady was slightly elderly, around 60, but she was COVID infection. She was given steroid, but she presented with her DNA hepatitis B. She was on antiviral drug for a long time, more than 5 years. But she came with an HBV flare with SGOT, SGPT was high, and DNA become very high. Even the patient was probably a few days maybe off from the drug. So don't stop the antiviral therapy for hepatitis B. And hepatitis C is a short-term therapy, but hepatitis B is a lifelong therapy. Should not be stopped. And there is a risk of flare when the patients of hepatitis B acquire COVID infections. So these are the anything I will be happy to answer the questions.
Thank you for sharing your thoughts and very practical suggestions. So I think you have mentioned about remdesivir and steroids in CLD patients. What about anticoagulation? Now, those are compensated
A-
and having perhaps
the anticoagulation there anticoagulation can be given, and yeah, I suggested to my colleagues who are treating the patients of cirrhosis that I suggest that okay, anticoagulation has to be given. But problem is that decompensated patient, where the patient is in a child C cirrhosis, then everything you have to be very careful. And one of my patients of child C cirrhosis was admitted, and she just after getting the it may not be just but he developed a hemoptysis after anticoagulation, low molecular weight heparin. So definitely it's a compensated cirrhosis. Anticoagulation should not be withheld. Decompensated, very careful, and you have to think of the benefit and risk and benefit is you have to judge. And or it is recommended that it is justified to withhold the therapy until you are compelled that COVID infection is really a problematic in patients of child C cirrhosis with COVID infection. Everything is detrimental and problematic. And that patient, one of my colleagues suggested to give tocilizumab. Then immediately I was, oh no, absolutely no.
So there are a few questions. First is, what is the recommended cutoff value for stopping remdesivir? I think hepatic enzymes is mentioned, Professor Pal.
5 times the upper limit of normal. That is, 40 units. Then it is 200 milligram, 200 international unit of SGPT.
Another question is about role of famotidine in COVID-19.
There are few data that famotidine has been shown to be, but there is only some reports, but there is otherwise that famotidine, as far as my knowledge, that there is no therapy effect for COVID infection.
Another question is that if someone presents with increased liver enzymes and has cirrhosis of the liver, how to distinguish whether this is pre-existing induced pre-existing disease problem or COVID induced?
Actually, you have to think that it is likely to be COVID induced because most of the patients of compensated cirrhosis, the liver enzymes are normal, except for those who are on the starting of therapy of autoimmune or acute, or particularly in alcoholic. It is very difficult to decide. If the patient is on alcohol, there is a component of alcoholic hepatitis with cirrhosis. These are the group of patients, there is a mortality is also high, and if they acquire COVID infection, then you have to be very careful that to giving the therapy for COVID. So only thing that if you feel that there is a child A cirrhosis and the SGOT SGPT is not up to the range of 5 times the upper limit of normal, then I think the therapy should be given. And monitoring is very important. If just after 1 or 2 doses of remdesivir, if the SGPT is shooting up, then you should stop the second day or third day of therapy. So daily or at least alternate day monitoring is very important.
Thank you, Shrujit. I think we'll thank Dr. Chaudhary and move on to your last speaker. The last speaker is Dr. Subhash Todi, who also needs no introduction, the well-known intensivist and currently Director Critical Care in Medicine, the HOD of Department of Academics and Health Research at AMRI Hospital, Kolkata. Over to Subhash.
Hello, good evening, and welcome to this multimedia Pulmocon, which Dr. Partho is organizing and virtual for the first time. And I would like to thank him for inviting me. I have been asked to give a personal experience, share my experience of COVID over the last 8-9 months. We have been taking care of around 5 ICUs, each ICU having around 12 beds. So huge load of COVID, critically ill COVID patients. So I will just describe my experiences over the last few months. When we started with this COVID epidemic, most of the studies which were coming out they were focusing on initiating therapy based on a particular pulse oximeter saturation. For example, the dexamethasone study, patient have to have a saturation of 93 or below on room air while at rest. Another study, your uh, plasma studies or anticoagulant studies, all the studies, tocilizumab studies, they were relying on certain uh, uh, SpO2 is either 43 or 44 at room air while the patient is sitting. And so it became such an important number, that pulse oximeter saturation. And as you know, these are usually recorded by the nurses. So if somebody is 92, even if he is looking clinically well, he might not have too much of an infiltrate in the CT scan, then he becomes a candidate for remdesivir and steroids. So saturation became a very important parameter. So over months, we never used to doubt the pulse oximeter readings in these patients. But with what we, because now the patients started checking their own pulse oximeters and all, and what we realized that the pulse oximeter readings can vary a lot in the same patient depending upon which hand we are doing, where in which finger we are doing, and also whether the patient is sitting or patient is doing some exertion. So one has to, so what we started is, we started looking at pulse oximeter in both the hands and all the fingers, and the one which gave the highest pulse oximeter reading, we asked the nurses to do the pulse oximeter only in that finger. So that becomes a kind of a benchmark for us to kind of compare pulse oximeter. You know, most of the studies had said at rest saturation 93 or below. So what about the patient who's at rest is 96, but as soon as he walks, it falls to 90 or even 87, 88? Is he not a candidate for remdesivir or steroids? We were not very clear about this part. So a lot of us started giving patients these drugs even when their at rest saturation was normal, but on slightest of exertion it started falling. So those were the two observations in the initial phase that we were confronted with. Then came an era initially when giving a BiPAP or a nebulizer or a high flow nasal cannula was a no-no in the intensive care unit. We had tussles with a lot of other referral consultant who wanted to give it, but we said that we are at risk of having COVID if we give this aerosol generating procedures to the patient. And this was based on a few studies, and the guidelines adopted this, and all over the world people adopted this. And this is something which have come into this COVID era, because in our medical practice, we hardly change our clinical practice. Even if the best study published in the best journal, it was found that it took years for doctors to change their practice. And here, within weeks or within a month, even the major journals started publishing studies which were not that robust. The guidelines started publishing those, and we physicians immediately adopted that. So basically, if you go through the initial British thoracic guidelines and the other guidelines, they say not to use aerosol generating procedures. So we had patients who were on non-rebreathing, and then they became, if they became hypoxic, we never gave them a trial of high flow or BiPAP, and they were immediately intubated. And this went on for a few months. And then the studies started coming that this aerosol generating procedures are not that infectious, so we can go ahead. And then all the guidelines suddenly changed, and we also changed our practice. So now almost many of our hypoxic patients, almost all of them before going to ventilation, are either given HFNO or they are on BiPAP or both. So you see within a span of few months how we changed our practice. So that is something which is very peculiar to this COVID epidemic, where the journals start publishing the different guidelines and the different articles which are probably not that robust, and we have to adopt what is being published in the major journals. So that was one that I thought that I will share with you, the way the practice changed of giving this respiratory oxygen support. The third thing that we noticed in the COVID was adoption of what is called awake proning. That was an eye opener, because as the studies started coming, that if a patient self prones, or if we prone in an awake patient who is on oxygen or nasal cannula high flow, their saturation improves, and we saw that, and that was a game changer. We never used to prone patients who used to come to us with pre-COVID era with pneumonia, or say for pulmonary edema or ARDS. VQ mismatch is VQ mismatch, whether it is COVID or non-COVID or pulmonary edema. So probably this was something which was an eye-opener. I think it is not specific to COVID, and I think we should start using this practice even in non-COVID patients in future, those who requires high oxygen supplement, to put them prone and to see whether saturation improves. And we did save a few patients from getting mechanically ventilated by this maneuver. So another thing which kind of opened our eyes, a simple maneuver which can be done starting from emergency department, and if a patient is taught well. So we did a proning protocol, left lateral, right lateral, prone, and then supine. And we are still doing it in an awake patients. Fourth thing which we noticed was what is called happy hypoxia. Now, what is happy hypoxia? A patient who is desaturating even down to mid-80s, but he's talking to us, he is not complaining of any problems, and he's kind of talking, and he's even talking to his family members over phone, and we are almost ready to intubate this patient. So a very peculiar thing is happening in COVID, where because of probably of a good lung compliance in many of these patients, and there is lot of perfusion problems in this patient, they become very hypoxic, but they generate a reasonably good tidal volume, and that's why they don't become dyspneic. Still, the pathophysiology of this happy hypoxia is not very clear, but this is for sure that even in severely hypoxic, in a subset of patients, they might not complain of dyspnea. But the respiratory rate may be high in these patients. So that becomes a very, very important vital sign in COVID patients to look at the respiratory rate. And that made us think of what we call as a ROX score. This we started doing a couple of months back because we were in a dilemma when we started putting patients on high flow nasal cannula. Some of the patients gradually got better, but some of the patients deteriorated and required mechanical ventilation. And the patient who failed high flow nasal cannula and required mechanical ventilation fared very, very poorly. They had a very stiff lung on intubation, and it was very difficult to oxygenate and ventilate them. So we started thinking that while on high flow nasal cannulas in the initial few days, can we have some idea as regards which way these patients might be going? You know, the ROX score is SpO2 by FiO2 divided by respiratory rate. And this was utilized in high flow nasal cannula prediction of mechanical ventilation in non-COVID patients. And we utilized the same ROX score, which was done in every shift by our nurses. And in non-COVID patient, it was shown that patients having a ROX score of less than 4 are most likely to fail and will require mechanical ventilation. And even our experience has been similar. We have been seeing that patient with ROX score of 2, 3, 4 ultimately don't do well. So we are still ongoing that, but that is something which is easy to do at the bedside. The nurses can do it. SpO2 by FiO2 divided by respiratory rate, provided you count the respiratory rate very carefully. That will give us the best uh, indicator
কিন্তু
of which way the
আমার
patient
ব্যাপারটা
is
হচ্ছে আমি
progressing.
বাড়ি
So
পেতে পারি,
utilizing
ফ্ল্যাট পেতে
SpO2
পারি,
and,
কিন্তু
and looking at the respiratory rate becomes a very important marker. Another thing we noticed regarding this oxygen issue was what is called orthodeoxia. Now, orthodeoxia, as you know, is very common in hepatopulmonary syndrome. That is, as soon as the patient sits up, their oxygen saturation falls. Whereas on the lying down situation, their oxygen saturation is okay. Lot of our patients who have been otherwise stable did manifest the same. And then the literature in many of these major journals started coming of the autopsy studies in COVID showing lot of neoangiogenesis, that is new capillary formation in around the alveoli. And as you could recall, in hepatopulmonary syndrome, the reason for orthodeoxia was increased capillary formation, spider telangiectasia in these patients and having pulmonary arteriovenous malformations. So something similar was probably happening in this patient to give rise to orthodeoxia. So that was another observation that we had. Another thing which came up in the COVID era, which has been controversial and debatable, is patient self-inflicted lung injury. That is, if a patient is put on positive pressure non-invasive ventilation, and if a patient is spontaneously breathing, his intrapleural pressure becomes very, very negative because of very high respiratory drive. So if an intrapleural pressure is say minus 20, and we are putting a patient on positive pressure of 15, then his transmural pressure, that is pressure inside the alveoli minus the pressure outside the alveoli, becomes very, very high. That is 15 minus minus, that becomes plus, and 15, 30, 35. And that goes on 24 hours a day, and that causes severe lung injury. So some experts like Gattinoni and Marini, they started saying that patient with high respiratory rate, patients having COVID, better to intubate them early. Otherwise, they keep on going into a vicious cycle of what is called PCLI, patient self-inflicted lung injury. And once they get ventilated, they become very stiff. We have noticed this, but then there is a debate whether it is the COVID itself was worsening, or was it because we have put this patient on high flow or BiPAP, and that's why the patient has worsened more. There has not been any definitive study on this. At the present moment, our philosophy is to continue with the high flow until and unless the patient starts showing signs of fatigue, because the outcome of ventilator in these patients are not very good. I will discuss about that. So that was this concept of P-Silai also came up. Then came this ARDS. Once we ventilate a patient with COVID ARDS, now again the description says that there are two kind of pathophysiology, the L type and H type. Patient having a very low lung compliance or a high elastance, that is low lung compliance or low elastance or very high lung compliance. Patients having requiring very high PEEP or not very high PEEP. Patient who will benefit from prone. So basically, in one situation, the lung alveoli are not flooded so much. It is mainly the microvascular thrombosis which causes lung injury. This is the L type. And the H type is the classical ARDS type. But the further investigations and observational studies have found that even in non-COVID ARDS, the same kind of distribution is there of L type and H type. So it is not very specific for COVID. And basically, the ventilatory management should be the same as the standard guidelines. And that's what we have been following. We have been comparing our mortality on patients on mechanical ventilation in COVID patients and non-COVID patients over the last 8 months. So we have been keeping a track of these patients every month. What we have found that the mortality is around 30% in both COVID and non-COVID patients. So it is not, there is a general kind of an impression that patients with COVID have a higher mortality when they undergo ventilation, but we have not found it, at least in our data over the last 8 to 9 months. Same kind of mortality, risk adjusted mortality, the same severity, still the mortality remains the same. Now, regarding ECMO. Now, ECMO is something which came up in the H1N1 era, and that changed the utility of ECMO worldwide. The same thing started reflecting in COVID. Now, the question is, should a person who is young, otherwise have a good quality of life, now is on ventilatory support, either requiring FiO2 of 80 and above, having PF ratio of 50 or below, or having a huge dead space, that is PCO2 of less than 7.2 and having a PCO2 above 60, 70, which are not improving with prone ventilation. Should we be putting this patient on ECMO provided financial and technical issues are sorted out? We have done that in about 20 plus patients. Some other centers are also doing it. Now, our experience has been mixed, because what we have found that a pneumothorax is sometimes very common in these patients, because probably a lot of these patients have subpleural fibrosis. And even you go for ultra protective lung ventilation, there is a very high chance of pneumothorax. And once they get a pneumothorax, it causes bronchopleural fistula and very difficult to get these patients out of ECMO. So pneumothorax, even in non-ECMO patients, have been a big problem, especially with patients with bilateral diffuse infiltrate fibrosis, because a lot of these are subpleural pathology and they give rise to pneumothorax. So another thing which one has to keep in mind as regards ECMO, so we are still continuing with our ECMO, but the results are mixed. Then comes this post-COVID fibrosis. We have quite a few patients who had a very severe COVID, went on to ventilator, required ventilator for weeks, had a tracheostomy, came out, but eventually we were just not able to wean off the oxygen support. Now, some of these patients we have sent on home oxygen. Some of them were on BiPAP through their tracheostomy at home. Now, initially we thought that these are, especially if a patient is young, candidates for lung transplant. As you know, in our city, we don't do lung transplant, so we referred them to other centers. Many of them were not able to go to those centers. But over time, as we started following this patient, we found that they gradually improved. So I think if one sits tight and just follow these patients very carefully, avoid steroids, even all these pulmonary vasodilators, antifibrotic drugs do not have so much of an impact. We give it, but on not a very robust evidence. But a good care, good oxygen support at home, and sitting tight, maintaining their nutrition. They are very anxious. One of our patients, we were not able to get rid of oxygen. He was so tachypneic. But as soon as he was given a tranquilizer, his oxygen level went up dramatically overnight once he had a good sleep. So it was nothing to do with steroids or your pulmonary vasodilators. So I think those parts have to be given more important than these drugs which are not been proven. And steroids make them so weak. Steroids causes a lot of myopathy in these patients. And we think that their oxygen saturation and tachypnea is due to lung disease. But a lot of our patients, they are not able to walk, they are not able to sit, their muscles and diaphragm become so weak. So it is very important that aspect has to be looked into. Now, nosocomial infection, that is again a big thing in patients with COVID. We are following the Western studies, Western guidelines on use of steroids. Some lot of centers, though we have stopped using tocilizumab, though there is a very recent study which is again advocating. But the question is giving so much of an immunosuppressive medications in patients who are on ventilator in the ICU, surrounded by multi-drug resistant bacteria, knowing that these patients will require a prolonged ventilation. I think many of our patients probably we are losing because of nosocomial infections. So we have to go slow and we have to go low in the sense that even probably steroid we personally don't give for more than 10 days. We don't exceed dexamethasone above 8 milligram or equivalent of methylprednisolone. Another thing that we are very much keen of diagnosing now is what is called COVID-associated pulmonary aspergillosis. As you know, in pre-COVID era, studies done in India had shown a very high aspergillus count from ICUs in India. They have done studies in certain centers. This is because of the lot of constructions going on. We don't have so much of HEPA filter, which are very costly, and our ICU structure and design are very primitive. Now, patients who are immunosuppressed on steroids and on ventilator and all, this aspergillus can cause severe pulmonary infiltrate and hypoxia. Now, there are new guidelines which have come up. Previously, it was bronchoalveolar lavage galactomannan. That was the gold standard for diagnosing invasive pulmonary aspergillosis. But in COVID, a lot of people want to avoid using bronchoscopy. So nowadays, there are guidelines of ET aspirate galactomannan or even serum galactomannan in non-neutropenic patients. And we have found quite a few patients having a very high ET suction galactomannan. And sometimes it is so difficult to differentiate lung infiltrate of COVID from fungal. So a lot of them do have antifungal treatment. It's either voriconazole or this new drug isavuconazole that we start in these patients. We had a patient from Agartala who was COVID and he recovered probably because of isavuconazole, because his ET galactomannan was very high. The cutoff of galactomannan is 4 in the ET and it was very high. He was given a 6-week course and he gradually recovered. And lastly, just a few minutes on, we do give a lot of medications to these patients like heparin, steroid. Convalescent plasma we have stopped giving. And we only gave convalescent plasma to patients who had a negative antibody and had a normalish D dimer, because we should not give plasma to a patient who is prothrombotic. So somebody having a very high D dimer, we should be avoiding plasma. Probably this is the only disease in medicine where we give heparin and plasma in the same patient. So basically we have to go back to basics. I think that is what in many countries, like in Germany, for example, Germany had a very, very low mortality rate of COVID. And what they did was no fancy stuff, just basic, good, intensive supportive care, avoiding too high of immunosuppressive drugs, and they had a very good outcome. So I think we should also be following this, just give basic, good, supportive medical and nursing care, and then we will see a better outcome. We should be avoiding very high dose of immunosuppressive for a long time. Even if we use it, we should objectively prove that this patient is improving on my therapy, in the sense that if I decide to give very high dose of Solumentrol, I should show that my PF ratio has improved from pre and post by at least 20-30%. If the PF ratio remains the same, we should not be continuing high dose of immunosuppressive in this patient. I've taken a lot of time. So I would like to thanks again. This is going to be a pre-recorded version, so I might not be there for your interactive questions, but I'm sure the other panelists and the chairpersons will be answering them. Thanks a lot.
Arthur, can we ask all the panelists to be present for question and answer, or should we end the session?
Well, you can ask questions to other panelists, and you can also answer yourself if you're comfortable. And of course, then you can close.
I think what Dr. Todi just mentioned about convalescent plasma. Just this week, there is a published in NEJM where they have tried early convalescent plasma of high titer in older adults, and this is perhaps the only positive trial of convalescent plasma, where they have determined the neutralizing titer and where the neutralizing titer was very high, and they have chosen older patients more than 50 years of age, and it was given very early. I think convalescent plasma should be given only for those niche subjects. It's more antiviral rather than in the hyperimmune phase. So we have to use it in the viremic phase, not beyond the first week when the hyperimmune phase sets in. Any panelist, any parting thoughts, any take-home messages you want to emphasize?
So we have two more questions with us.
Yeah.
And one is incidence of ILD increasing with COVID-19?
I don't think so. The ILD patients may fare worse with COVID-19, but I don't think, it's a post-COVID fibrosis. This is not synonymous with ILD. Anyway, I think we can ask Partho, what is your thought about that?
Yeah, I agree to you. It is not yet decided whether we'll call it a post-viral infection, interstitial lung disease, or a specific post-COVID fibrosis. But morphologically, it quite often looks similar to DPLD. So I'm not sure what the experts are going to decide in future. But for now, we say it post-COVID lung fibrosis.
And another question asked by Professor Shomaranjan Pal is that what is the threshold for starting antifibrotic therapy? I don't think it is really validated now still. So it's all in a sort of experimental phase. What is your idea about using nintedanib and pirfenidone in the post-COVID fibrosis, and what point of time you really start?
If you see the evolution of the radiological changes in COVID pneumonia, you can find that in some patients, there is actually the course is like there is initial ground glass opacity, then it organizes, then some fibrosis sets in, or the organization resolves gradually, getting back to ground glass opacity and then getting cleared. To my experience, I have got only some experience of treating post-COVID patients. Most of these lesions, they reverse a lot. If there is a subpleural fibrosis to start with, or if there is a severe pneumonia at the beginning, perhaps there is a role of starting early nintedanib like that. But you have to take care of the coagulation issue in mind. And once you find the patients have got already set in the CT scan showing fibrotic changes, there is a role of antifibrotic possibly, and there are a lot of trials been going on. In fact, myself has also been involved, and my experience is that, although not very mature, that most of the patients, they resolve themselves automatically. And in some patients, perhaps antifibrotics may have a role, but we are not sure which are these group of patients. We have to wait a few more weeks, perhaps.
Another thing is that, in some patients, we find persistence of GGO. So if the GGOs persist, is there a role for extended use of steroids for them, maybe in a low dose?
I don't agree, because GGO comes in the two phases of COVID pneumonia, COVID-related lung problem. The initial part GGO, then it organizes, then it goes to GGO again in the resolving phase. So we don't have many times serial CT scans, and it's not recommended also to get them done to actually evaluate the changes. But if you find GGO in the first 2 weeks, first week, it is probably the initial GGO. Then If you find it after 6 weeks, it is resolving GGO, or 4 weeks or 6 weeks, it is resolving GGO. People had followed the CT scans till 3 months. And there are also studies of following the radiological changes after 3 months. But it's been said that in most of the cases, the resolve and the resolution also involves morphological presentation of GGOs. So GGO is a non-specific thing, and GGO primarily doesn't mean a fibrotic pathology for sure. So it is better to observe GGO, and you have to assess the patient as a whole, especially the other parameters of interstitial involvement like diffusion capacity with spirometry. So this is important. But some patients, for unknown reason, they go downhill and they have got progressive fibrosis, and they end up with very bad prognosis.
I think we have had instances of lung transplant as well in a few of the patients worldwide. So I think they must be very bad patients. So
it's a very peculiar thing. It depends upon the individual person's response to the insult, and the insult by the medications, been modified by the medication, you can also say. And I have seen the representative CT scans of very stiff, almost solid lung, the CT scans of honeycombed lung like idiopathic interstitial fibrosis. I have seen NSIP-like feature. I have seen a lot of GGOs, a lot of organizations. I think organization is a very common feature in COVID. And if you see organized lesions, these lesions are likely to improve in most of the cases. A bit of follow-up is essential. If there is, people have tried to see what are the changes that has got a very slow resolution or poor resolution. Subpleural fibrosis and fibrotic strands from pleura down are the two I remember. So if there is subpleural fibrosis at any stage, I think it is a good reason to start anti-COVID treatment. And the initial pneumonia, its severity is also related to the development of subpleural fibrosis. So I think that the recommendation may extend to that category of patients also, but I'm not sure about any present recommendation or any present publication. What I'm talking is about my knowledge about of reading about a month back.
I think if there is no further question, I think we should call it a day.
Yeah.
One final question from Dr. Narendra. Yeah. Can you hear me?
Yes, yes.
Yeah. You see, there is no lockdown. Nobody is maintaining the proper mask, proper sanitization. But the incidence and the death ratio is decreasing day by day. What is the cause for this? What is your opinion?
I think, in my opinion, there are two causes. I think in India, we have achieved a substantial amount of herd immunity by now. I think maybe in the order of around 50% maybe. And the other thing is that, average age of Indians is 8 years compared to the West where it is 45, 46. So maybe, a lot of young patients who are affected are asymptomatic. And that is why, the incidents, they are not getting admitted, consulting anyone for doctors. So they are remaining asymptomatic. And maybe, the herd immunity level has also gone up in India. So in my opinion, these are the two factors which can explain the less fatalities and the case states. But it is my individual opinion.
I've got a little thing to add to it. May I request you to mute those where from the sounds are coming, noise is coming. I think Indians have taken too many things as prophylaxis. We do not know which one is acting. If you ask your patient, everyone is taking something or other. That may have a role in actually preventing the illness severe.
I have seen patients of families where there are 10 or 12 patients in the same family and they have been given the same prescription of 12 drugs. starting with ivermectin, doxycycline, vitamin D, vitamin C. So 12 drugs standard for all the members of the family. So I don't know whether we are doing more harm or good by
That is possible. Plus, there is a concept that Indians have some trained immunity.
yeah.
Perhaps that may be.
I think so. That is also responsible. We are exposed to a lot of tropical infections, and we have some amount of immunity to a lot of microbes.
Is there any? A lot of practitioners are prescribing aspirin or clopidogrel in post-COVID period. How rational it is, so Vijita?
I don't think so. This is basically endothelitis. And if you have to give, so you have to give some amount of immunosuppression. It is not a atherosclerotic process where antiplatelets are going to work. I think Ansal will be able to.
Yeah, clopidogrel definitely has no role to play. As far as the aspirin is concerned, there were some old studies which showed that aspirin could prevent deep vein thrombosis. So some studies or some recommendations are there about that, but very dicey. As you mentioned, it should be anticoagulation or immunosuppression. That should be the standard treatment. So either anticoagulation or nothing, as far as anti-thrombotic therapy is concerned.
So Vijita, you may kindly.
Yeah. So there is no further question. I will like to thank all the panelists to spend so much time on a Sunday evening, sacrificing their family.